It's rarely the case that something that happens to the host of this program becomes fodder for an episode of The Agenda. But a few weeks ago, with my family doctor on vacation, I tried very unsuccessfully to find another doc to check out my aching knee. Because I struck out so many times, I ended up visiting 2 hospitals on 2 different days, 2 hours drive apart, getting 2 ultrasounds, 2 blood tests, and stressing the resources of a healthcare system already under too much stress, all because I couldn't get in to see a family doc. Danielle Martin is perhaps Ontario's best-known family doctor. She's also chair of family and community medicine at the U of T, and she joins us now to talk primary care. Great to see you again in person.
Great to see you too,
We've done
Steve.
this a few times on the line, but it's great to have guests back in here. Let's start with first principles. The family doctor is so important to the overall healthcare system because why?
Saves money, improves health, and improves equity. So there's very strong international evidence over many, many decades that health systems that are based on a solid foundation of primary care and family medicine produce better outcomes in terms of better health and are less costly. But for people, it's also important because we know that family medicine and primary care are where we catch things early. They're where we follow chronic disease and try to keep it under control so that we don't experience complications. And it's also the place where people develop a relationship with the health system. You know, I like to say that if when somebody asks me a favor, do you mind just taking this patient? I'm happy to do it, but I remind them that they're asking me to make a 40-year commitment because that's what it is. You know, it's a long relationship that we build over time, and it becomes your point of entry into other parts of the health system. So for each of us as individuals, it's critically important. And for the health system, there is no number of hospital beds that we can build and no number of emergency departments that we can open that will allow our health system to function in a normal way unless everybody has easy access to family medicine, which is exactly what you experienced.
Well,
Steve.
I'm drawing from, my inference that I'm drawing is when you say catch early, that's how you save money.
That it's partly how you save money by catching early. You save money by preventing. You know, a simple conversation that leads somebody to quit smoking or to take a vitamin D supplement or to increase their physical activity can have huge prevention ramifications down the road. It's where we manage chronic illnesses and prevent them from getting bad. And so, you know, if we can manage a person's diabetes or their high blood pressure or their cholesterol in the family medicine environment, we can stop them from having a stroke. We can stop them from having a heart attack. So these are significant outcomes that are, of course, devastating to the person and to the family, but also extremely expensive to manage in the health system. And they put you in the place where you least want to be and the place where we all least want to be, which is in the hospital.
Right. 15 million people in this province. How many don't have a family doctor?
Almost 1.8 million people don't have a family doctor or are loosely attached. And another 1.7 million people have a family doctor who's age 65 or older.
Which means they're going to lose them soon.
I mean, you know, that's what the data would suggest, and we've all seen in the pandemic an acceleration of that. So about double the number of family doctors retired in the pandemic as compared to prior years. And so we're seeing an acceleration of that. We're seeing it, of course, all over the health system, not just among physicians, nurses, and other healthcare providers are retiring, are choosing new careers. It's been a time, right? And so we're feeling those ripple effects across the health system. And I'm very worried, Steve, that we are at a point of crisis in family medicine and primary care. And there is, it won't be possible to fix healthcare unless we fix this first.
This may be a dumb question, but it wouldn't be the first time I asked a dumb question, and that is, how is it that 1.8 million people in this province don't have a family doctor?
Yeah, it seems so simple, right? And it turns out it's one of those thorny problems where we say, okay, well, I guess we better train more family doctors. Then we train more family doctors, and it turns out they don't go and work in the places where we need them to work, or they don't practice the kind of family medicine we need them to practice. And then we say, okay, well, we should build teams. But it turns out actually that if you build teams, then you have to put in place an infrastructure around that, and the government's not funding those kinds of teams anymore. And so we keep kind of trying to move for the simple solution. And it turns out the complex problems require thoughtful, multifaceted solutions, and sometimes they take time.
So we can't just say that because some government 20 years ago failed to do X, Y, and Z, that's why we're in the pickle we're in.
No, because of course there's more to it than that. So yes, of course, we would be probably in better shape if we had been training more family doctors throughout. Yes, we would be in better shape if we had put teams across the province so that people aren't relying, as in your situation, on a single provider. So if that poor guy takes a holiday, his whole practice falls apart. I mean, it's not a tenable situation for him or for any of the patients he cares for. But I also think we have to acknowledge that we're in a situation of an aging population. And so that changes everything. The family physician workforce is aging. The patient population is also aging. People have many more chronic diseases. So I don't see in my practice anymore people coming in with, I just, whatever, came to have you look at my toe. People come with 5 things. That's and very often now in the post-pandemic era, one of those things is a mental health concern. And so it's just getting more complex. The work is getting more difficult. And for those of us who chose this career, it's an honor and a privilege to do the work. But it would be easier to do if we were functioning in an environment where the system could support it.
Let's stipulate right here. Now, my situation doesn't amount to a hill of beans, as they say, but I remember when going through it, thinking to myself, I've lived in this province pretty much my whole life. English is my first language. I have some sense about how to navigate my way around the healthcare system. Not a fabulous sense, but some sense. And I remember thinking the whole time, if you're an immigrant, if English is your second language, if you've only been here for a couple of years rather than 60 plus years, what would you do?
Yes.
What's the answer to that? What would they do?
The answer is people go to the emergency department, and who can blame them? Or they go to walk-in clinics, and who can blame them? And I think those are stopgap measures. They exist in the system. We need them to exist in the system. But none of us thinks that that's where we should be getting our day-to-day care. And so, the answer for that person who is struggling to figure out how to navigate the system, they show up in the hospital or in the emergency department. I mean, as we all know, the role of the folks in the emergency department is to deal with the crisis at hand. They're not also, while you're here, going to make sure that you're up to date on your mammogram, or your tetanus shot is up to date, or have a conversation about the relative risks and benefits of having a PSA test. I mean, they're not going to do any of that stuff, and so we're not keeping you well in that circumstance. And the data do support what you've said, that people who are new Canadians, people who are living in poverty, in low-income neighborhoods, are even more likely to be unattached to a family doctor or a primary care team. And of course, those are the people who, on the basis of their social determinants, are the ones who most need it. Right. So we've got it all backwards, and we are in a situation where we're going to have to invest energy and also some money in fixing the situation so that we aren't funneling everybody towards the emergency department where things are at a breaking point.
Well, play that out for us if you would, because you said 1.8 million people don't have a family doc. So if, for example, they need to get some medical attention and they end up going down to their emergency department, if that situation gets replicated time and again at ERs all over this province, what's wrong with this picture?
Well, I mean, this is how we end up in a situation where we hear about emergency departments, hitting the breaking point, people waiting hours and hours for care. We also know that in that environment, you're much more likely to have staff burnout. You lose your staff, you have to close your emerge. That puts stress on the emerge down the road. And it's not a tenable situation. It's also just really bad care. It's not what any healthcare provider went to school to do, to try to deal with the kinds of things that should be handled in the community in an emergency.
And a patient doesn't want to wait 8 hours to see a doctor.
Who would?
Yeah.
And none of us wants to see an older person lying on a gurney on a stretcher, transferred in from long-term care. This is not how any of us wants it to work. But the issue is that the problem that hits the headlines is that overcrowded emergency department. And so the knee-jerk reaction is, well, we better put more money into emergency departments. We better build more hospital beds. Rather than saying, well, how did all of these people end up here? And is it possible that we could have done something to prevent it?
Okay. You are nicely leading us to where we need to go now, which is we are where we are. So we got to make some decisions today that deal with the issues that you have described here. So what do we need to do today to try to make sure that 10 years from now, we still don't have 1.8 million people, or God forbid, even more,
Right.
who don't have a family doc.
So the first thing we have to do is we have to build teams. We cannot be in a situation where most people are relying for their care on a single individual family physician or nurse practitioner or any kind of primary care provider. When you have a team, which should include, yes, a group of doctors so that everybody can take their summer vacation, or somebody falls sick or goes on maternity leave, their practice is taken care of, but also many other kinds of healthcare workers. In this era where mental health is at a crisis point in Canada, most of those teams need to include a social worker or a registered psychologist or another person who specializes in mental health, because otherwise what happens is I, as the family doctor, am spending my time doing counseling, which I can do, but actually a social worker would do a better job of it, and that would liberate me to deal with the medical issues that are coming in that only a family doctor can deal with. Similarly, pharmacists, nurses, physician assistants. There's very interesting work happening in the US with a new job called scribes. These are people who will enter all of the information into the computer so that I can be looking at you instead of looking at my screen, entering stuff into it, and allows me to be more efficient and move more quickly and see more patients per day. Community health workers who go out into the neighborhood and get to know who lives in the area, what do families need, what are the health needs that are unmet.
These are all on the same team.
Yeah, I mean, I'm not saying you need every single one of those people on every single corner, but you can build a network in a neighborhood or in a community where each of those team members is doing the thing that they are best suited to do. And then you don't end up in a situation where you're relying on the most expensive providers, doctors and nurses, to do everything. And then, yes, of course, we need to train family physicians, we need to train nurse practitioners, we need to compensate them in ways that are consistent with the kind of care that we want them to provide. We need to support them in neighborhoods. But the very first thing we need to do is get out of the doctor-centric model and move to more of a team-based approach. That's what's going to allow you to be able to get your knee taken care of in the moment where it's aching and your family doc's on vacation.
And as it happens, I do have a family doc who is on his own and always has been, and I guess kind of likes it that way. What do we say to the presumably hundreds of family doctors in this province who are solo and want to stay solo?
Yeah, so I mean, I think that's a difficult conversation, right? One of the things we can say is, let us offer you coverage. I don't think anybody's going to turn that down, so that they know that their practice is taken care of when they go away. We've seen this advent now of virtual care in the pandemic, huge amounts of healthcare now in the province of Ontario being done virtually, probably in family medicine somewhere around 40% of visits occurring by video or mostly by telephone. And that can be really good for patients. I mean, a lot of my patients love it. They don't have to come in. It's just something that can be dealt with a conversation. Not everything. Not everything can be dealt with that way.
But some things.
But some things can be, and it's a less of a waste of time. It's also helpful for people who have jobs that make it hard for them to take a half a day off to come and see their doctor. So there's an equity dimension there too. A team can, if you construct it right, we can be offering those solo practice folks supports that will help them take better care of their patients. I'm not saying we all got to move into their office, but we can connect them with resources and services that will help them to serve their patient population better. And I think almost all of them would like to be able to do that.
I get this notion of you got to create teams, but how do you even begin to put something like that together?
Well, we have some teams in the province. About a third of Ontarians, like 30% or so, are taken care of in some kind of team-based model. And that includes a wide range, something called a family health team, there's a community health center, there's a nurse practitioner-led clinic, there's an Aboriginal Health Access Center, there's millions of different flavors of teams, but we've got them. And so one of the things that we can do is begin to just kind of extend those out. There's also a new kind of collaboration occurring that really took off in the pandemic called OHTs, Ontario Health Teams, which are sort of loose associations of hospitals and family docs and social service agencies in a neighborhood. So like a lot of this is about taking the resources we've already got in the system and networking people together. I mean, if you can imagine, Steve, that there are many parts of the province where until very recently, the hospital had no idea who the family docs were in the neighborhood, had no way of reaching them or reaching out to them. So a pandemic hits, you want to get personal protective equipment, to the front lines, you don't even know who to call, where the mental health agencies never met with the hospitals and the community health centers never met with each other or never met with the family health teams. Like in a neighborhood, we're all taking care of the same people, but no one was talking to one another. So a lot of the work that has to be done, they're not easy fixes. It's about building relationships between the different groups that are taking care of people in a community.
Let me ask you about money.
Yeah.
We're spending $75 billion a year in the province of Ontario this year on healthcare, this fiscal year. That feels like, I don't know, but it feels like a big number. Feels like it ought to be enough. Is it enough?
Well, we're not spending it right. So I hesitate to say that there's no place where investment will be needed, but probably one of the reasons why there is going to be a requirement for investment is because we're not so great at uninvesting in things. Most of that $75 billion is being channeled into hospitals and doctors. So, this is the core of Canadian Medicare. We said we were going to pay for doctors and hospitals for everybody. That's mostly what we pay for. But times have changed since the 1960s. We're now in a universe where people are older, they have many chronic diseases, the care that they want and need is in their homes and in their communities and neighborhoods. So we've got to now invest in those parts of the health system, something that we've been saying for decades. Now in this, dare I call it the post-pandemic era, the coming out of the pandemic era, it's critical. There is no way that we're going to get through this recovery without investing some money, yes, into primary care and communities.
Is it a problem in Ontario that there are still a lot of people who go to med school who don't want to be family docs, they want to be specialists?
Yeah, so it's an interesting thing, and we have seen a decline in the number of graduating medical students over the last number of years in Canada and in Ontario who choose family medicine as their first choice. And so some of that has to do with who we're bringing in to medical school. Some of it has to do with what we call the hidden curriculum, or the messages that we send to people, subtle messages about specialties or specialist care being more fancy and important than primary care, more glamorous, certainly in some, not all cases, better compensated. But, some of it is also that we're in a situation in the health system where students see what they would be coming out into. And so, part of it is if we fix what it feels like in primary care, when students rotate through their family medicine rotations in the community, it's going to look like a really exciting and wonderful place to work. When they see a bunch of burnt out people who are not sure whether they would choose this career again, it's not a great advertisement for the discipline. The other thing that we're seeing happening that's, I think, really important, Steve, is a larger number of people who are being trained as family physicians. We train a lot of them at University of Toronto, who then graduate and decide, rather than practicing general comprehensive family medicine, that they would prefer to be in an area of focused practice. So they're a family doc, but they only work Emerge, or they're a family doc, but they only do sports medicine, or they're a family doc and they only do psychotherapy or palliative care or what have you. And these are important services that our communities need, but it just means that we're training people. We think we're counting family doctors, cranking them out off the assembly line, but we're not getting a comprehensive family doctor at the end of it. And so we probably need to be exploring more why people are making those career choices and seeing whether we can make it appealing to those people to do a little of both. For many, many years, I delivered babies as part of my family medicine practice. I did that, Wednesday night was my night on call. The rest of the week, I took care of my general patients in my practice. So just thinking about how do we make it possible in people's lives to both carry a comprehensive family practice panel and have an area of interest where they're contributing, as a person with enhanced skills.
Okay, in our last minute here, the big political question. Governments clearly understand what's required. What confidence do you have that it's going to happen?
I think we're going to have to push hard for it. Every one of those 1.8 million people who are loosely or unattached entirely from primary care, needs to make a phone call to their MPP, needs to ask their local hospital, what are you doing to entice family doctors to come and work in the region? All those of us who are lucky enough to have a family doctor need to help to raise this issue in the public consciousness, because we all know that our political decision makers respond to pressure from us as citizens and voters and residents of this province. And that's our job, is to tell them what matters to us. And if we keep building hospitals and long-term care facilities and failing to invest in primary care, we're going to keep getting the same result.
It's like that commercial. Pay me now or you can pay me later.
Correct.
It's cheaper now.
It certainly is, and a lot less painful.
That's Dr. Danielle Martin, family doctor, chair of family and community medicine at the U of T. Dr. Martin, always a joy to have you here on our program. Thank you.
Thanks, Steve.
The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.